This is the best time we can squeeze in. So, happy holiday, first of all. And we have a new year to come. And so, happy new year. So, I think we're going to get the report. We're going to basically take an opportunity of our pandemic. During our pandemic, we got a lot of technology development, so we can keep the distance. And then this is actually it's an opportunity for us to use this high technology to get the this is like a first meeting we get together. So this is I'm gonna make it. A lot of people participated this for a while and then don't have a good the entire pictures. So I think that this is an opportunity. Let me see if I'm gonna move on. Give me a second to have a little technology thing. Okay, so first of all, I think it's a very straightforward statement for myself. We are and our No Pain Labor and Deliver Global Health Initiative is non-political, no religion, no business part of a non-profit organization. So I have a lot of messy, muddy experience, as you can see. Uh, the idea we have to acknowledge Operation Walk in Chicago. This is how I learned a lot of experience, and I went to China, Ecuador, and then the Indian, and I learned a lot of management skill and fundraising skill and so on. So this is the the uh, the starting point. So today we're going to talking about three things here. The first of all, reported accomplishment of No Pain Labor and Delivery Global Health Initiative since the year 2006. Somebody probably know that we sometimes we see 2008. 2008 is the first trip we made, but initiation was 2006. We're going to present current ongoing project since the pandemic, and then we discuss our future works and activities. So I think we need everyone's opinions within. First of all, I think the thank you so much for all we done. So this is what we did. This is what you contributed, and so I gotta first of all report what haven't done, and then to give everyone a good pictures, and also suggest that I thank the people who actually suggested to organize this Zoom meeting. So this is a good idea. So the background, where we started. Low label epidural. This is how we actually started point, and then we discovered the high C-section rate, and then we also find that there's a traditional single players in the labor and delivery room. So this is how we actually got started. So this is a recent publications in the I think Lancing, in basically talking about what is the ideal uh, cesarean delivery rate. The This dot line actually indicated that after this, our uh, newborn mortality and the mother's maternal mortality is no longer changed. So in other words, this is ideal point. It's about 19%. And this golden line is the what we started, with the average Chinese uh, cesarean delivered. And this red line is the United States currently about 30%. So that's we still it's not ideal. We still have a little buffers. So we're gonna work on this high cesarean delivery rate because this is not become a rescue maneuver for more maternal and then neonatal mortality. This is something else. This is a publication we recently discovered. Published in the Plus One. But as a basic is the idea we have at the very beginning. So why are the labor epidural rate is so low, and why cesarean delivery rate is so high? So this is what we asking Chinese perinatal care providers, including our obstetrician, anesthesiologist, and neonatologist, midwife, and the labor delivery nurse. So what we actually see, the number one, they want to basically we're asking them a solution as well. So this is their solution to increase the anesthesia manpower. This is the one thing. If you're interested, read the whole article. This is a QR code. You can get access, and then you're gonna go the whole article. This is a special article we published in year 2016, and basically talk about why we need to do global this global health initiative. So strategy, the methodology, and approach, and the goal. The goal is try to facilitating sustainable increase the vaginal delivery rate by increased access to the safe, effective neonatal labor analgesia. Therefore, decrease the cesarean delivery rate. That's how we actually started. So what is it? No pain labor delivery global health initiative. This is a U.S. non-governmental, no religion, not for-profit organizations now. And since year 2018, we registered as Apgar Care International. And then this is before that was associated with Northwestern. This is more a volunteer-based labor and delivery multidisciplinary team. And then we are evidence-based medical education approach. And we set up a goal, basically outcome improvement with goal-oriented operation. And the motivation is that we try to screen out the hospital where the administrator are motivated to changing their practice and improve their outcomes. And we scheduled stepwise project once a year. So this is what we actually are, how we actually motivated our local hospitals. So what was anticipated challenge? This is what we have, seven of them. And we soonly discovered the fundamental one is hospital administration. And then we're also talking about our obstetricians, our midwife, our anesthesia, and our neonatologist. And also we talk about the system, billing code, and the patient education. So this is how we anticipated it. So this is not new. It has been described and then discovered in the many articles and many authors, and this is just an example. The basic anesthesia 24/7 to provide a safe, effective labor anesthesia need import elements. This is it's a workforce. So the workforce in the low and the middle income country is low, much lower than what we have in United States, in Europe. So there's no sort of a manpower to work on this. Even we do understanding our anesthesiologists played big roles in the patient safety. Give you an example. I met one anesthesiologist in Ghana. They basically have only one anesthesiologist in the entire area, like let's say, population of like a Boston, population of Columbus, like me, where I started. So there's no chance to provide analgesia for those women. So this is a just example, and then there's many example. If you want to read the article, this is what we gotta write it. So it is possible to solve the issues. We, based on the survey again, we just published this year May, and everyone, either an OB, our anesthesiologist, our midwife, they all agree. Number one, to solve this puzzle is increase in the anesthesia manpower. This is a very everybody understand it. No power, no gain. And a very interesting part of it is anesthesiologist Red Bar, who also said, more importantly, even if you get more pay and manpower is not number one, it's a secondary issues. So this is maybe it's something we can work on. This is just tell you what I said. So this actually is the second manpower in anesthesiologist's view, probably the secondary. They probably want to have increase more salary. And talking about more salary, so we actually working in one of our Chinese hospital academic center in Wenzhou, and we try to understanding how much impact. I think the Dr. Yunping Li and participated in this project that we published the ASC annual meeting with a little bit of square this much increased from zero to a little bit, and then before was this a green this a blue bar, and after this it's a red bar. So red bar was dramatically increased, and then we're talking about that little increased indirect increased by 58%. That's the talk about 11 months later. So this is dramatically increased their like a revenue, the hospital revenue. So it's not like a direct cost. It's an indirect gain financially is the one thing we have to emphasize. And also we discovered the cost, the income revenue from cesarean delivery, revenue from the blood transfusion actually went down. Those are two things went down. And surprisingly, one's surprising, one's not surprising. So conclusion was when this epidural started, cesarean decreased, cesarean rate decreased, and the incomes increased, and the efficiencies increased. This is a very important message. Unfortunately, this is because the not universal. It's not able to generalize these numbers, so we cannot get the formal publication. But this is something we tracked and we understand it. We also got remember we got a challenge of OB anesthesia. We don't have a manpower, but when we really conducting our medical education mission, we did got the challenge from the local community, local society. They basically says, how did you know the whole package you try to implanted in the Chinese hospital, it's not going to be harmful because the patient population is different, healthcare providers education training different, and the equipment supply is different, and the medications and the drug dose is different, and the labor delivery room environment settings are different, and legal part of it is different, cultural ethics is different. So this all those are different. Are you sure this all those protocols and the guidelines gonna work? So we face the challenge. We collecting the one of the data one hospital data from one of a municipal hospital near Beijing, about 2,000 miles or 200 miles away from it. So we published the first impact publication in year 2012. I believe that was in Washington, D.C. And then the meeting actually broadcast the news titled Ancient Dreams of the Pain-Free Labor for Chinese Women Become Reality. So this news was broadcast in 5 languages, 10 countries, and hundreds websites and medias. So it was very well received. And we suddenly publicated this data 3 years later on municipal hospitals. So what we find, if close to 3,000 patients, and then we see the cesarean rate decrease, episiotomy decrease, and the postpartum blood transfusion rate decrease. That was surprising. And forceps rate is not changing. Apgar less than 3 or 5 minutes decreased. And then very surprising to find that the neonatal mortality decreased by 50%. So this is we do believe it's not just epidural. It's more likely the anesthesiology in the service, and also we decrease the cesarean delivery rate. Those are the co-founding factors to make this happen. And a blood transfusion, probably not only single factors. It's got to be more other things involved. This year in March, we published the one studies in the rural area where hospitals and where 90% of farmers, and then there's a very poor prenatal visit. And then we find that our education with good analysis is called interrupted time series analysis. This is we published the papers use this analysis of twice. This is one of them. So basically what they say is they're predicting based on previous situation, they're predicting what further going to happen. And that when we actually visited them, and then we have real data, so compare the predicting data and the real data, they find that this has happened. Something did happen. So this is a very interesting data. So we also challenged, this is okay, well, let's say you have a high risk patient population. How did you deal with them? So we have a 2-phase study. So this is a second phase. So we basically interested in the neonatal data. First 3 months, they just changed the new hospital to new labor and delivery room. So we tried to get the baseline. So the primary outcome was neonatal NICU admissions. And then the green line is the epidural rate. The red line is the cesarean delivery rate. And then also we see the 7-day mortality, that's the purple line. And we got our NICU antibiotics usage. We have the NICU, the intubation rate, that's the blue line. And Apgar score is the yellow line. So what we actually find after we continuously use the epidural on the second phase, and then also we use the new definitions of year 2014 ACOS definition of arrest of labor, and we did find everything went down, get better. And then even with the justification from epidural rate and C-section rate, this is consistent. So this actually publication, local hospital published about last year, I think, with our analysis. And then we are not only based on our data, our study, and then we have a local hospital who actually collecting data, published the impact study as well. Those are another three studies recently published. The one is the Tuzawa already mentioned, and the one is the in the Wuhan. Everybody knows now. Everybody know Wuhan. So that's a one of the hospital, the provincial hospital in Wuhan, and they published their data. So this is a. So now what happened is the since year 2006, we have a little timeline. We have a initially year 2006, that's in November. We postponed year 2007 because we're not ready. We don't have a manpower, we don't have equipment, we don't have a donation, we don't have a lot of things. The year 2000, I only have like two people, so we couldn't do it. So we launched the first trip of the year 2008, which is, and then we actually, believe it or not, this is not our first pandemic. We already had a one pandemic, the H1N1 flow. This is the year 2008, 9. This is our second year. It was devastating. We have 33 people already got a ticket and vacations, and we canceled the trip literally within a week before we departed. So that was the big impact. And then obviously we already get 2 years post the suspending, and then we don't know next year. We planning. I think the second week of the next year, it come in June, but we don't know yet. So what happened to the local hospital? We have 108 collaborated hospital within three different three different levels projects. So 68 of them finished the first step of the project, which is basic obstetric infrastructure program. We used to call the first level. And then we have a 21 hospital finished the second step project, which is advanced OB anesthesia 1, 2, 3. That was the previous when we started it, we call that name, and then we now changed the name called Modern Labor and Delivery Room Suites Advanced Project. We have 19 hospitals, and basically 18 hospitals and 19 hospitals finished the third steps, so which is the credential project. We have 378 checkpoints to make it a credential. And then after this, and then we give them a plateau. So also we have 8 of those 108 hospitals finished our optional project. Before we're talking about 3 like a must-do project before we move on this. So we have 2 hospitals finished the maternal mental health project, which is year 2019. And we have 2 hospitals finished baby first project, which is a combination of maternal fetal medicine with neonatologist. This is a very unique. And then we have 1 hospital, the year 2016. I think Dr. McConney is here. He's a superstar at that time. And then we call Shanghai International Multidiscipline Simulation Training Camp, what happens in year 2016. And we have 1 model hospital, which is Shanghai Jiahui International Hospital. And I was physically went there year 2018 with Alex Lin, who let me see, who was obstetricians of my colleagues in Northwestern, and to build up their labor and delivery room floor and the department of anesthesiology. And that was a very, very outstanding, very, very unique situations, and then really like American hospitals. So we use this as a model hospital. So we, believe it or not, have, I think it's, I lost the count. I think it's around 1,000 individual physical visits to the Chinese hospital together. And since we started, which is, I really couldn't believe it, and I never imagined it. But thank you so much to participate. Our volunteers from more than 120 institutes in the United States, Canada, German, Belgian, Australian, Singapore, and China. And I don't even know how many teams we formed. I do know the peak time, year 2016, we have 20 some teams together. Okay. And then we have 120 team members during the week of No Pain, Labor and Deliver Global Health Initiative. So thank you very much for this contribution. You see, we together, we make a difference. So what happened to the local hospital? What happened to the system? So year 2008, we have less than 1% of labor anesthesia rate, as everybody probably already know. And we have a more than 50% of cesarean delivery rate. The reported was a 46.2 year 2007, but you know, sometimes we have a population, we have a little bit of problem with the population. So depending on which population you study on. Year 2018, that's the 10 years mark. We committed for first 10 years, right? So we have a 913 hospital was chosen as a pilot hospital by central government. And then they estimate about a 50% annual national childbirth. Okay, so official report in that year, the label epidural was a 16.5. Our goal is try to get 10%, but that time it's already more than what we have. And then the cesarean delivery rate is 36.7%. Okay, this is their national survey data. And then we are very, very close to our total epidural amount in the United States. We talk about 2 million. And then China, if you count it as 16.5, is about 1.7 million because the population base is different. And then cesarean delivered US the 30, 31, and then now the China was 36.7. So we are getting closer. So this is, we talk about 3 steps. So we give a global picture. So 3 must-do project. 1 is established 24/7 safe, effective label epidural service. And then 2 is advanced OB anesthesia 1, 2, 3, which means 1, 2, 3. One service for high risk Praetorian team consultation. 2 emergency team maneuvers. 1 is a mass blood transfusion protocol, and 1 is a C-section delivery. And 3, in talking about 3 protocol for vaginal delivery, because those people most oftenly to go to C-section. For instance, if somebody who has a C-section before, and then we most likely will be C-section. And then the people has the problems more position of babies. And then we got the external version, so that decreased the cesarean delivery rate. And then pre-eclampsia, the patient most likely go to the cesarean delivery. So we created 3 protocol for vaginal delivery. So try to specifically decrease the high risk populations the cesarean delivery rate. A credential modern labor and deliver suite. We have 378 checkpoints, and we have a 3-day assessment, and then we have a discussions, and then we got a certain points, and then we do an assessment. Okay, the optional project that we just mentioned is the maternal mental health project Baby First project, and then the Sing 2 project. And then we do have some project developed during the pandemic that we're going to talk about later. So people ask very often, say, why happens? We have a hard time to make the sustainable project in the local, and then we always giving a fish to feed a person a day. This is a project that I did in the past. Basically, typically, we donated money, recruiting patient, got donation from equipment and so on, and then we got associated hospital, and then we'll go over there to operate in one day, 10 days for Operation Walk Chicago. We fixed a lot of joints, and then we left. And then we beneficial the people physically over there, but we did not make anything changing in the system. So global health model, this is what new things develop. Basically, try to teach a man a fish, how to fish, and then feed them for a lifetime. But the global health initiatives, especially on the medical education part, it does make this happen. It does make it sustainable. We tracking their data, and then also we changing their system. So this is a why. Principles are different. The other things that people may understanding, but if you're not OB anesthesia, no obstetricians, and you probably don't know, there's actually something developed in California ahead of time, year 2008. This is called the California, the Quality of Medicine, the CMQCC called Toolkit. And basically, they have a list of things by the time. And this is their website. And then in the US side, there's a called Patient Safety Bundles. They get started the year 2011. And they have a similar situation developing. This is their website. Our project is very unique. Not only just we are open to internationally. So we have a unique challenge, not only team not working together yet, but also the portal has not developed inside of their own specialty and subspecialty. So we have to like steps forward. So we work on the OB, the hemorrhage. We got team practice. So we're talking about resuscitations, the C-section. We talk about credential. We talk about safe rate, decrease the cesarean delivery rate, and then we have certain population work on the hypertensions with the pregnancy, and then we have high risk consultation, and then maternal the mental health issue. So we are right on time. This is the time to make a change. We do have some references, even we develop a little earlier, and we have a different challenge. So we are pretty unique. So this is a second why we have a references. With the time, I listed all the publication we published in, not all, incomplete publication, I should say. Collecting about 22 of them up to this year. And we started in publication year 2013, I believe. And then with everybody's efforts, and we made the changes. The red colors means that this is a pretty high end of the journal in the certain fields. And the blue highlights, the names are the team members who contributed to the studies and writings and so on. So thank you so much. We make it together. We made a change. And we have a randomized trial. We'll have a lot of impact study. And we have a lot of our review articles and so on. We also published lots of books. The amount of publication is beyond my imagination. Even I participated in all those things. On the average, probably I was participated in one book a year at least. And then we have a patient educational book is already get a second version, and this is our first actually uh, patient educational book to talk about the woman cost in every country, collecting all the data from different countries, all the women's, the Chinese women's, how they actually deliver babies, and then we also got a lot of other things. And this is our three-step books. We have textbook in there. This is two of those evidence-based book we translated from Lee Fleischer's books. And this is three new publication books. The year 2018, we actually published the book and rank as top 10 medical textbook in the field. So congratulations for the people who involved this writing. And we have a two version of the chestnut obstetric anesthesia, and I think that Dr. Weaker taught the Parkinson's in the UT Dallas spent a lot of times efforts to work on that one. And we also have the Red Book. It's one of the obstetricians in the University of Arizona, Dr. Thomas Chen, and he had published a book in a English version and a Chinese version. This is a very, very well accepted book. And the pocket book and manuals, Chinese like the manuals. Tell me what to do. Don't have to tell me what reason. So this is a very good book. And we actually work on the care bundle book. Try to use in this approach. It's in the written. We have one of the registered the journal since the year 2018. It's got Journal of No Pain, Labor and Delivery Global Health Initiative. Okay, and it's not in the PubMed. It is actually because the target audience are different, so we cannot go on that PubMed. We have three levels of audience: the patient education, nurse, and the physician providers. And also we have monthly columns, and very specifically Journal Club, dialogues of practice, the parameters, basically our how to interpret our our updated guidelines. And then we have a care bundle. This is the book we mentioned. We keep writing chapters, and we already had a lot of chapters. And then we have a learning and develop in labor and delivery care. So this is very interesting. L&D in L&D care. It's a very interesting name. And also we have some the other columns in this journal. The news, special articles, and patient education. We have an audiobook. Basically, our patient audiobook has been renewed, and we have a new version. We'll put on an audio, and then eventually we're going to get the new version of the book. We also have some video clips. So this is a more multimedia and journal. And then we so far had 6 months publications. And this is the covers we have. And we have a picture. This is the most the recent one. We have this is our first one, and then we have some animal cover. We have some scenic. We have a seasonal, like this is the Christmas time, a year 2017, 16, and the seasonal. And then we have our project related covers. So if somebody interested, this is a QR code. You can actually get the whole list of a journal. It's all English, Chinese. We probably gonna work on the English as well very soon. We try to basically understanding what local women's physicians, nurses, administrative person um, try to understanding them and try to listen to them. And those are two videos actually were broadcasted and during the World Congress of Anesthesiologists in the year 2016. And this is a QR code. If you're interested in watching, probably interested in time, just put a code on it. This is in the YouTube. And also we have a Chinese version too. That one is no pain, introduce our project basically. And we just published the second one, which is about 2 days ago. No, a week ago in German. They converted to virtual meeting because there's a pandemic surge, COVID is surging again. So this is a Euro Anesthesia TV 2021. We use the title, it's Global Medical Education Translated to Better Maternal and Infant Outcomes. So we got one of the local hospital focus on this. So we'll finish the talk about first one, which is the overall pictures, what we haven't done, what look like, and then give people, give our team members, give the public the idea and what look like and what kind of things we've done and what achievement we have. So now we're gonna work on the projects that we developed in the pandemic. During the pandemic, we remember this. We talk about this. We'll talk about later. Now we're talking about this. So we're taking advantage of our technology. We basically developed the hybrid webinar on labor and delivery care bundle, which is basically in the local hospital. They work in the conference in a multidisciplinary setting, and online we take advantage of the people from different places, and then we set up a time, and we have a multiple specialty, and we have two sides speakers, one of the Chinese sides, one of the U.S. sides, and then we have a very specific topic, and we're talking about the how we take care of things. So, for instance, last one we just had, we'll talk about the intrauterine resuscitation. Okay, so we also developing one-stop enhance of child birth recovery. Get an idea from the Chinese Chinese tradition. They have women that stay in the bed, do nothing, just take care of feeding the baby, and everything else, family members or some people support a person to help. So we got this idea. We also recognize the things that women worry about mental health, worry about the kids not doing well, worry about the body size changing. We need to get the weight control, and we got the breastfeeding, the whole thing. We use that concept. We develop the one-stop shopping for everything. So this is a project that currently being developing, and then we already had a one talking, and then we'll get more to come, and then we aimed to private hospital on this time mostly, and also uh, accepted some public hospital, and it also not only happened to in China, but also happened in the United States. We have one site that we're developing in San Francisco. There's a one site that we are about developing um, in the Los Angeles, and I just talking to someone who is in Hong Kong. Well, they also have some interesting to develop such project. So this is a joint effort from multiple society, multiple specialty. We are thinking about after Spring Festival in China, we gotta establish a Zoom journal club, which is an English version. We have a Chinese version on the remember the our journals monthly. We pick up an article. We have a certain format, assess the quality, and also we assessed the methodology part, and then we have a free the comments in the different specialties involved. So we have been working on this, and we'll publish the book, one book already, and we have another book is already submitted, and I think this is probably a time we got to work on the English. We got to I got to talk later. This has probably become our new approach to our global society for our trips. So this is what look like. We basically has a before this sort of conference or webinar, we already have well written the review chapters. And then we invited our people locally in both sides and then different specialties. And then we have a settings. You see some people at the round table and some people single. Single means that the people on the invited speakers. So we comments on the things. We'll talk about the interaction and then addressing all the issues. So this is it. And then we got the obviously have a 1 hour slide presentation talking about the topic. And then we started a case. We started discussion. This is what it looked like when I on the webinar. So we're gonna move on the third, the objective, which is discuss our future works and activity. Remember, we have a 10 years of commitment in the Chinese society. We'll not give up. We still keep going, but we gotta switch gear to different society and more helping more people. So some people tell me you need to dream big. So I got to dream big. I'm dreaming about, we got to take care of 50% of the world woman populations in the world. So, and this is we already took care of 20% of them. We still have a 30% to go. So this is what we got to do. So we are reaching more. So this is a review of I having outreaching our society, different countries and different society community, and since year 2014, I believe. And I went to Japan, actually visited Tokyo. We have multiple discussions and so on, and we actually planning something going on in the meeting we just finished last year. They have a Japan sort of sessions, and I was invited to talking about this. There are issues about their labor analgesia provided uh, by opticians and not anesthesiologists. So there's a very tortured concept. I went to Taipei year 2016 or 17, and I have the 010 building, 101 buildings, and with the three they are maternal fetal medicine persons. And after discussion, everything, we did not get the moving forward. Basically, the same situations like Indian opticians, they afraid of the anesthesiology invading labor and step their toes, invading their territory. So speaking of Indian, so we had many multiple meetings and everything. Yunping's colleagues after our trips and initiated these discussions, and we working with the hospital with hospital chains with 7 hospitals, and we already to the point we had a written agreement submitted to them and asked them to read it and sign this signed it and returned. And then we just got uh, silent forever. So we got the key person find out was their obstetricians totally against the idea. They want to get a C-section, 5 o'clock, so they can go home on time. Before the pandemic, we already discussed about the make it a team to Armenia, and we already submitted their agreement and so on. And in the middle of processing, pandemic started, so we stopped right there. And I have one colleague who's very motivated to to bring us to his private previous hospitals employee, and we're gonna make it happen. So he know this well. I don't know when he actually in the meeting. He said he's going to here, and I have a resident who's from Casimir. His uncle actually owned the business, so we started processing again. We stopped it during the pandemic, so we're not moving forwards. So, by the way, I think we gotta work on this one. I having sort of a casual talking, recruiting the people in Asia, all the Asian country, pretty much, and Eastern European country, and then also Africa, and then the South American country. So those are so far. So again, some successful, not really. We did not have a physically sort of milestone to moving forward. So this is my new approach, which again our Zoom technology, and I just speak in one of their annual meetings in the Indian Society of Anesthesiologists in do Delhi, and 2 months ago, and then we introduced our project, and then we have not heard anything from them yet. Hopefully, we can have more to collaborating and moving forward. And this is what I find when I talking to them and give a talk, and then they have a similar problem. This is the cesarean delivery rate in the public institutions, and when we high about 300% higher versus a private institute was a 400 plus higher than before. So this is jump 300, 3 times higher. So this is happening to India. The article can be found in the QR code again. And this is basically broken down which their region, before and after. And then this is what they find. Okay, they have a really dramatically move on. Some places already hitting 50%. This is the last slides. Basically, number one, tell us we have a lot of logos we develop with the time. This is the logo probably people recognize most. This is our care bundle logos, and this is our baby first logos, and this is our maternal mental health logos, and this is the one for our one stop enhance the birth recovery from a childbirth. And this is our simulation, same square boat. This is the logo. Okay, thank you very much for your listening. So now is the questions and suggestion and comment. And I think it's before we intentionally mute everyone. Now you can unmute yourself and or raise your hand. We can help you unmute, or you can typing things in the comment sections and the chat section so we can answer your questions. Thank you.
Hi, Dr. Hu. You hear me?
Yeah.
Yeah, okay.
Thank you, Dr. Shah.
This is Yun from Ohio State University. The summary is excellent. The plan for the future is exciting. So it's very good. So in China, what's the future plan for our labor delivery?
I think that in China we still gotta work on those three. We still have like a um, three kind of the project. One is the mandatory stepwise three-step project, and depending on the needs. And secondly, we got to work on the optional project, which is also after they finish their stepwise project, we can have a they choosing baby first. They get a mental health projects and simulation projects. So depending on the situations, and also we still gotta working on our pretty much opened the project that we just mentioned about during the pandemic that we developed, which is uh, the uh, the webinar project, and also journal club for high-end hospital when they actually can make a lot of studies, um, and then communicate with with outside of China, and then so lifting them higher. And I think that's pretty much, and then one stop enhanced project, and which is more on private hospitals, and this is a global efforts. But I think the Chinese have the 坐月子 women stay on the bed for first months, so we can actually work on that one. So this is pretty much a Chinese side. So the global side, the other countries, I forgot to mention that at the end, we gotta we'll change our approach. We gotta using journal club as approach. So outreaching our global society, and then we blending in our like a our standards, the stepwise project. And also I think the different country probably has some different needs. Like for instance, if we got to work on the Japan, they they are different, and then we'll work on the Taiwan, they're gonna be different. So we are pretty much gonna work on based on what they need for care bundles. I don't know whether it's an answer to the question.
Yes, you did.
Thank you for your question.
Hey, Dr. Hu, this
Yeah.
is Ning Miao.
Hey.
May I ask some questions?
Sure.
I saw you said in China now the epidural rate is 16.5%. So
Correct.
who had epidural? Is a high risk patient or patient who requested?
Okay, so it's a very interesting question. It's a very good question. The used to be the epidural is only for low sort of risk patient population. So this is what they try to. I saw sort of my gut feelings. So they have lots of contraindications of epidurals. For instance, baby not doing well, you're not going to be those epidural. Preeclampsia, you're not going to have epidurals. That sort of thing. And then if people have a VBAC, you're not going to have epidurals. So those are the situation. Now, the situation changing. We are promoting the anesthesiologist in the labor and delivery room 24/7. So then they are moving on the high risk of patient populations. And then the hospital, I think, is not universal, like not mandatory, but assuming it will be very soon. The anesthesiologists don't provide a service 24/7, stay in there. But a lot of hospital, especially the hospital associated with us, they get an idea 19 hospitals in our first row. They all in the labor and delivery rooms, and a lot of hospitals are working on that one. So I think that's the current status. 16.5 is mixture, and a lot of things, as I mentioned, they are not even provide anesthesia in the second stage. They think the second stage is a problem, but they do. We discovered surprisingly, second stage is the place we actually got the more beneficial for both babies and women.
Thank you. Another question, is that the anesthesiologists in China train as devoted for the OB, or just a general anesthesiologist who also work in the OB suite?
Yeah, that's another good questions. And basically, what happened was there's no such a specialty, subspecialty existing, and I think it's just like still on our early stage. Whoever do more, and then they probably gonna do more. And then the training is not standardized. This is probably the next things we could do. I think it's a very it's a very important questions. We are sort of working on this maybe in the futures. One project is just how to training OB anesthesiologist. It is a need because a lot of people had impressions about anesthesia nothing. Epidural, I can do epidural, but they did not know that there's a lot of things behind the epidural.
Thank
That's a
you.
neat, that's a neat
Thank you.
question.
Yeah, thank you very much.
I think I'm reading the comments. I see Brian Mahoney, very beginning. He joined us. He moved to the Mount Sinai, New York, and then keep sending us resident and attendings and enjoy part of it. And then he's also superstar for the same lab training. And then people just probably forgot about the No Pain Labor and Delivery Global Health Initiative, but remember him. So I got the comments from Crystal Lee, and thank you very much. And I got Dan Zhao Huang, who is our the psychiatrist in the Emory, who's in charge of developing the maternal mental health projects, and also work on the GPS project, basically the one-stop enhanced recovery project.
Hey, Dr. Hu, I think there's some issue with the connection. I couldn't hear you now.
Dr. Hu, you are muted.
Okay. Did
Yeah.
It's okay now? Okay. Sorry. I have to use my plan B. My plan A was a stop on time. I think to finish the presentation, it stopped working. So this is my plan B. I'm talking over the phone now. So I cannot see the comments. I'm just reading the comment. Oh yeah, I just mentioned Dr. Wang is the psychiatrist at Emory. She actually helping develop a mental health project and a one-stop project as well. She very motivated, and she got the special training, went training for GPS, went other trainings, certified. So this is a very, very appreciative. Where I can find the comment, the other comment, I see that Dr. Yinping actually made the comments too. Any more questions?
Yeah, I have
Yingping,
one.
do you have any comments? You spend a lot of time on it, and Kathy, you spend a lot of time on it.
Yeah, my question is, I know in China, the general hospital, like tertiary or general hospital who cover the other specialties, normally don't encourage people get epidurals, and only the maternal and children hospital, they promote epidurals. Is that situation going to change? I know there's some new policies published recently. I think that's maybe a hurdle for most difficult, like the high risk maternal care, because the general hospital who has normally have the highest risk patient, but they don't have the personnel or manpower to provide any obstetric anesthesia service.
Yeah, this is something we gotta work on it. I let me mute up. I think I'll back online. It's a technical issue sometimes. Okay. So I think this is another very important questions, important things that we're gonna work on it. Basically, what it says, basically our anesthesia, OB anesthesia, not. I think this is basically the things that we already understand at the very beginning. The anesthesia, OB anesthesia, not just for labor epidural, and then the people did not understanding this very much, and then still have a lot of misinterpretations. So I think with our promotion, especially the Cassie actually was leading this AOA, Advanced OB Anesthesia 123 project many times. I think with this project populated, the people started understanding this. And then this project that was designed for populated idea of OB anesthesia and tell people vividly what should be done and what needs to be done. Okay, I got another two comments, and since I'm able to open it, comment section is Dr. Xia. So nice to see everyone. Happy holiday and to everyone and your families. And we got the Dr. Jinping Wang from MGH. Fascinating job, very impressive. And during this pandemic, do you have any backup plan to replacing the in-person teaching in China? So I think it's kind of what we can do, what we can do. So I think that we working on one stop, the enhanced recovery project. This is our next step. We'll work on it, and it already has one project going on, and basically bundle care webinar, and then we think of recruiting not only hospital we has been working on it, but also we recruiting more hospitals to join us. So and then it's actually very unique, and because when we go physically it is like a supplement. When we went there and we actually very noisy, very hurry up, and we have like a thing the timelines, and we have to do this, we have to do that, and then we have a lot of people, and then we cannot talking and all together. And so I think the 1 hour Zoom webinar sort of take care of that business and then make this happen and are more focusing and more comprehensive. So this is actually our things. One stop project, we have somebody trained it. Well, the Su Wei has been trained for GPS, and so we actually has the physical person work there And then we just need that project moving. We need some volunteer work on that one. The general club one, I think it become more needs because based on the experience we have in the past, we help a lot of people to work on the publications and document what we've done, and then actually publication based on my reviewing experience was not sort of as good as right now. I think that now we have most of the publications, most of the manuscript I received have very well written, at least the quality part of it. Okay, remember we have a general club, we have a quality control part of it. So actually, they have all those elements in there. And I think with the, especially when we're talking about the document in English. So when we established general club, and we get an idea, basically welcome everyone whoever want to join us, we can join us and then talk. And then we have a designated person, we have invited the statistician, and we have our epidemiologist, and we have our OB, we have an anesthesiologist, we have a neonatologist, we have a midwife and a nurse, we have a neonatologist, we have a mental health specialist. We got all different sort of resources that already existed. We just need to put them together. So whoever want to volunteer and work on that one, this is going to be welcome to everyone because we're using the same language, English, to work on the war community. And whoever want to join any corners of Earth, we like them to join us. And this has become also open house kind of a concept for people to understanding us, knowing us. And this is a unique opportunity we never ever had before. Because of the pandemic, this has happened to us. So we got to take in this opportunity. We got our John Hopkins, Dr. Turcotte. He want to join us many times, and then unfortunately, pandemic has started, so we have connected, and then we have not sort of physically worked together yet. I think it's any. I think I got lost again. I think it's this is a. Can you hear me?
Yes, I can.
Okay, so I think there's your question is more of national guidelines and so on. This is what we provide. Okay, back. Back now. So what happened was we are physically helping them if they have questions, and we do actually helping them, and then provided information, provided the guidelines. Now we do have things to influence them to basically written good guidelines, and also talking about we translated lots of components of the US guidelines and also the European guidelines, British guidelines. So for them to have a reference, we have to understanding their language barriers and so on. So that's sort of the things that we work on their guidelines. And I believe the more and more we publish, the more reference they get. They have more pictures, combination with their own experience and so on. I think that the guidelines will be better and already improved because if we, their first the epidural guidelines, the label epidural guidelines, are published in the year 2008. And then if you pull out that guideline to the current guideline, that was dramatically different. Yeah. You can.
Any future plans to working with the health ministry? What we found, at least in a lot of our European projects, is getting the health ministry involved allows us to have a lot more resources, and then allows the local people to write their guidelines, and then we can act as references.
Yes, this is a very good point. It's a different in a different country, and culturally, and politically. So we have to work in sort of a very sneaky way to let them to get to the idea. Not necessarily physically helping them, but we can provide all the information. This is another way to do it. So this has been very successful, our approach. But I think that if you talk about some like other country, we can have a very open, and then could outreach in the government administrators or the head of a society and so on. That would be much easier. Yeah, we do actually get a lot of challenges from local society and administrators and so on. So it's a very, very tough question to answer. I think that we have to base on the project. So far, I think that our approach in China was successful.
Thank you.
Any other questions or comments? Weaker.
Hi, good evening, everyone. Hi, I have a comment to make, and I think this has been a great opportunity for all of us, and we all have benefited from it professionally, and make us, in general, a better anesthesiologist, to be honest with you. And I just want to make a comment that having gained experience in China, I have recently taken an opportunity to be to join the private group. I can still keep my professional appointment at UT Southwestern, because that's how I get my education opportunities and ability to read journals and work with fellows and residents. In the meantime, I'm also going to be employed by a private group. The private hospitals, among some of the ones in big cities, they do not always do the best practice. A lot of places use the old compound mode. They use high concentration locals. They do not have narcotic in the cassette. And the second stage pain management is a mess. And as far as staffing, somebody asked a question. A lot of places do not have obstetric anesthesiologists trained in a subspecialty. And many places do not even have 24/7 coverage. So some of the strange things that we thought only exist in China actually exist in the US as well, even in big cities. So part of my job is to utilize what I have learned, the approach, the knowledge, and everything, and to improve practice in the US. So I just want to comment, that's the best rewarding experience I've ever had, and I thank everyone for the opportunity.
Oh, thank you, Weaker. Weaker is the chief anesthesiologist at UT Dallas. Uh,
11, I think.
Yeah, oh,
you're
11. So I've been in charge of the one teams and have a fascinating working experience with Cindy Wang, right? You are the
I mean, I've learned so much from everybody in the team, Dr. Wang, everybody, of course. It's a good professional learning experience for me as well.
Yeah, personally, I got a very good development of those experience. Yunping, who's the best Israel and Harvard, and then she's a chief OB anesthesiologist over there, and she's on a vacation. She probably in the. Do you have any comments, suggestions, and anything?
So Lin, thank you, and also thanks to everyone. What we have achieved, it will be not possible without your help and without your contribution, without the the support from the department, from the hospital, from from you and from your family. This is a tremendous successful story. Everyone can share, everyone can be proud of it. One of the things I would like to say is, before we go to China, right? We practice there, we teach there, we learn there. Now because of COVID, now we do everything on the remote. It's different. I feel like next year will be remote as well, because China will not open right now, at the least for next year. And so one of the things I would suggest is, we often to give a lecture, like I want to give to you, right? I want to see mutual communication, what they want to learn, what kind of urgent things they want to learn, they have interest in to learn. So we can help them from our experience, from our knowledge. I often find in clinical practice, we always find very interesting cases. Actually, we never stop learning, even for ourselves. So it is an opportunity we can share the case, we can share the interesting case and the knowledge relate to this case. So that's my suggestion.
Oh, that's a very good suggestion. I think that the Chinese population, I think that not only Chinese population, world population, and this is more like a what's it called, PBLD kind of learning situation. We can implementing PBLD discussions based on the case. We develop their knowledge and we learn something each other. Great idea. Yeah, we can work on the project if we couldn't move on. I mean, 2022, we're still shaking. We have a couple to. Jinping. Is it Jinping there? Yeah, Jinping.
Yes.
Labor delivery nurse in Stanford. She was a midwife in one of the bigger maternal
In
hospitals
Beijing.
in China. Yeah, in Beijing.
Yeah. Mm-hmm.
Any comments, suggestions? And
Comments, just I really appreciate to have a time, really, because one of our Dr. Flood, one of the anesthesiologists, let us know that there's a program that can help China to develop like a no pain labor delivery stuff. We were so excited. And that was the year 2014. I was really pleased to go with a group, all the group of people from US, like either they're Chinese or American people, all the doctors from all different languages, they all come to China to give this teaching opportunity to improve their labor anesthesia and also to decrease the C-section. I was really impressed. And also I left China like 23 years ago. So even the practice from now is a lot of difference. So it was really good opportunity to learn from each other. So I love this program. I'm really looking forward to do more. Thank you, everyone. I don't have the suggestion yet because this pandemic is really, we can't do a lot of stuff, even though we did some online study thing to communicate with them, to learn from each other.
oh, we have to praise the Jinping, who many times joined our Care Bundle webinar. She had to get up at 3 o'clock in the morning to join us because of time difference. So we have not many of Chinese origin, Chinese speaker labor and delivery nurse. So we really appreciate her help. Okay, we got our. Also, we had Wang Qing. Hey, you want to
Thank
say
you. Thank you, Yingqun. I really admire you. Your energy, your passion. It's a privilege to join the team, and I had a good experience. I think the pandemic will last for a while. China probably will not open for another year or maybe a few years. So you may have to
be prepared?
yeah, develop project remotely. I think that's the future, near future.
Near future. Okay,
Yeah.
well, a lot of work. I think that Yinping gave us a suggestion. I think there was
Yeah, I think that's a good thing to discuss with them, and
yeah.
mainly through the Zoom meeting or Tengxun meeting.
Yeah, yeah. Dr. Wang is the was my classmate in the Michigan training. We worked together, and then she working really hard on the local hospitals, and actually all the healthcare person, the administrative person, and so appreciated her helps. So they still remember. Wang is the very impressed about her pushing, make everything happen. So it worked.
Another thing, I echo Wei Ke. I have been practicing in private hospital for over 20s. This is my 20th year. There are a lot of things still the same in the private hospital. So, but it's hard to change like the same in China. And also lack of manpower and maybe compensation. So people don't want to work too hard. So they get easy to give a high concentration epidural. So they don't have to be bothered. And there's another hospital I work. Then I have been pushing them to use like patient controlled epidural, and they don't have for years. So they are the same thing.
Yeah, there's it's called the provider centric operation versus the patient centric.
But it's understandable.
Yeah, it is understandable. Yeah. She helped a lot of writing is in division.
Oh, hi everybody. Yeah, really nice to be in the team of the No Pain Labor Delivery. And I mean, from the join the program, I learned a lot of things of myself too. And I practice the private group. And of course, not like academic the setting. And so our hospital is not like high risk, but a lot of details. And I learned from this No Pain Labor Delivery. Even I'm like the team leader for the past couple of years, and the work together with other very outstanding obstetricians and anesthesiologists, midwives, and nurses. Of course, work very closely with Dr. Hu too. So I really think this program is really fascinating. And for the past years, I agree with Wei Ke and also Yunping because we can't go physically to China, and then so it's actually this webinar program, and so maybe it's good to start some problem-based learning discussion on the problem in the WeChat group. Pick up some typical things to do further, make it better. Okay, thank you very much. This program, yeah.
Okay, we just look at her daughter, Anna. Do you want to say something? Anna's very motivated at helping the comments and she had a major of epidemiology. She went to Columbia University for public health, and then she loved dancing and painting. And our the covers of our journal mostly done by her. She has so we have like her painting all the time on her cover on our covers. Anna, you want to say something?
Yeah, thanks for inviting me to this call, of course. And I feel very blessed to be part of this program and being able to continue to not just further myself academically, but also, pass my academic career after and during my master's program, obtaining my master's in public health. And really just happy to be a part of No Pain Labor and Delivery and being able to utilize my different skills, not just for biostatistics and epidemiology, but also through my artistic endeavors and being able to, share a lot of my passions and experience with this group. So just want to really thank you for that. And
we're gonna invite you comments on the articles, and then we're gonna let you talk in the journal club, and then Zoom. How's that sound?
Right now?
when we start the project.
I would love to. Thank you.
Yeah. We're using your strengths. Now we got a lot of talking from anesthesia team leaders, and we got ask our opticians. I see the couple of opticians here. We have Dr. Liang. Are you there? Monica Liang. Did I pronounce right? Monica was the used to be working in the Honolulu, I think. Monica, are you there? Okay, and we have another optician, Dr. Wu Yanyi.
Wu Yingyi.
Wu Yanyi. Sorry, I always have trouble to pronounce your name.
That's okay. That's okay. Thank you for the opportunity. Actually, I kind of newly joined this initiative, and I learned a lot as a new U.S. OBGYN attending. But it also refreshed my memory all those lives back in China a couple of years ago. That's a great opportunity to work with so many excellent physicians and midwives and all those team members. I enjoy a lot.
Hey, thank you for your contributions. She also is an epidemiologist as well, and you got an education in Hong Kong, right?
Yeah, that was an MPH. But my major actually in economy and policy, not like pure epidemiology though.
Okay, well, you have a different angle to look at the things. And we're gonna need you to helping global, journal club part of it. And
sure. Anytime.
I already know you have very sharp eyes. You can comment on all things. And then,
thanks.
Yeah. So we have Dr. Liang, sounds like in France, name, right? We have Lee. You are very prudent. You have ask a couple of people to join. Lee, he is a basically based on the WashU St. Louis. The problem we have is I got all the email. Those email are bouncing back because the people changing the position, changing the place for working, and also some people graduate from the training programs and so on. So I got a lot of bouncing back. Otherwise, I expected that we got to have more than 100 people to join us. Unfortunately, we cannot reach them. And anybody else? We have a people from Hebei Medical University, the second hospital, Taipei University. 新红医生，新红主任，你有什么话说？ We have a local OB and obstetricians in China, Dr. Liu Xiaoli. 刘小丽，你有什么话说吗？ Yeah, they probably don't prepare for it. I know Liu Xiaoli can speak in English. I don't know Dr. Xing can do it. I think anybody else has any comments, questions, anything?
So
Yeah.
Dr. Hu, and everybody else, this is this is WikiTao, WikiTao. I'm just using this opportunity. We are expanding our work inside the United States as well. So if you know of somebody who's had experience with us or who's just a good evidence-based practice anesthesiologist, wants to be a chief of obstetric anesthesiologist in a Houston area hospital, Central Houston, let me know.
Oh,
job
cool.
offering. Job offering.
Okay, good job offer. We got a recruitment, recruitment package. So thank you very much for everyone who spent time with us, and then thank you, enthusiastic. And I think it's we again work together, we can make things happen. Thank you so much. Thank you for joining us. You have an all good New Year. Happy New Year 2022.
Happy New Year.
Thank
Bye-bye,
you. Happy
everyone.
New Year. Happy New Year.
Happy New Year.
Happy New Year.